This is part 2 of 2 in the section entitled Integrative Functions of the Cardiovascular System. With regard to hemorrhage, there is also a response of antidiuretic hormone. Antidiuretic hormone, or ADH, is secreted in response to decreases in blood volume. This is mediated primarily by volume receptors in the atria. ADH has two actions. First, it increases water reabsorption by the renal collecting ducts, that is, through the V2 receptors, which helps to restore blood volume. Second, it causes arteriolar vasoconstriction through V1 receptors, which reinforces the vasoconstricting effects of the sympathetic activity as well as angiotensin II. Some other responses to hemorrhage may occur. If a patient becomes hypoxemic, that is, decreased arterial PO2 following hemorrhage, chemoreceptors in the carotid and aortic bodies sense this decrease in PaO2 and respond by increasing the sympathetic outflow to the blood vessels. As a result, there is vasoconstriction, increased total peripheral resistance, and increased arterial pressure. This mechanism augments the baroreceptor reflex, which senses the decreased arterial pressure rather than the decreased PO2. Also, if cerebral ischemia occurs following a hemorrhage, there will be a local increase in the brain, especially in the cerebrospinal fluid, of PCO2 and a decrease in the pH. These changes activate chemoreceptors in the medullary vasomotor center to increase sympathetic outflow to the blood vessels, resulting in peripheral vasoconstriction, increased total peripheral resistance, and increased mean arterial pressure. Next, we'll discuss responses to changes in posture. This is very important, especially in elderly patients and patients that are taking adrenergic blocking medications. The cardiovascular responses to a change in posture or gravity are illustrated in a person who changes from a lying down position or a supine position to a standing position. A person who stands up too quickly may briefly experience orthostatic hypotension, that is, a decrease in arterial blood pressure upon standing, lightheadedness, and possibly fainting. Normally, a series of fast compensatory cardiovascular responses involving the baroreceptor reflex occurs in order to offset this brief initial decrease in mean arterial pressure. This can be seen in figure 4-38, which is on page 178, as well as table 4-10 on page 178. The initiating event in standing up is pooling of blood in the veins of the lower extremities. Remember that the capacitance of the veins allows for large blood volumes to accumulate there. When blood pools in the veins of the lower extremities upon standing, the venous return to the heart decreases temporarily, and cardiac output also decreases through the Frank-Starling mechanism. This results in a decrease in mean arterial pressure. This venous pooling also causes increased capillary hydrostatic pressure in the veins of the legs, which results in increased filtration of fluid into the interstitial fluid with a loss of intravascular volume. For example, if a person stands for an extended period of time, that is, a soldier who is standing at attention, filtration from capillaries can exceed the ability of lymphatics to return the blood to the circulation, which can result in edema formation in the lower extremities. Increased filtration of fluid out of the capillaries contributes further to the decreased venous return and decreased mean arterial pressure. If the decrease in arterial pressure is dramatic, then cerebral blood pressure may decrease and cause fainting. Here we see figure 4-38, and it shows the cardiovascular response in a person moving from a supine to a standing position. Table 4-10 on page 178 shows a summary of the cardiovascular responses to standing. We will discuss these in detail. The primary compensatory cardiovascular response to the decrease in mean arterial pressure involves the baroreceptor reflex. As the blood pools in the veins of the lower extremities and is not returned to the heart, both the cardiac output and the mean arterial pressure decrease. The baroreceptors in the carotid sinus detect this decrease in mean arterial pressure and send this information to the medullary vasomotor center. The vasomotor center directs an increase in sympathetic outflow to the heart and the blood vessels, and a decrease in parasympathetic outflow to the heart, attempting to increase the mean arterial pressure back to normal. The results of these autonomic changes are now familiar. We see increased heart rate, increased contractility, increased constriction of arterioles, causing an increase in resistance, as well as constriction of the veins, which causes increased venous return by decreasing the unstressed volume. Collectively, these changes increase cardiac output and increase total peripheral resistance, attempting to restore the mean arterial pressure back to normal. Box 4.4 describes heart failure and further illustrates the integrative nature of the cardiovascular system. Here's a description of the case. Here we have a 60-year-old woman who's admitted to the hospital after complaining of extreme fatigue and weakness, shortness of breath, and swelling of her ankles. Her clothes no longer fit around the waist, and she's gained 3 kilograms in the past month. She finds that breathing is particularly difficult when lying down. This is known as orthopnea. She also finds that sleeping propped on several pillows no longer brings her relief. She has a history of chest pain and shortness of breath upon exertion. Physical exam shows cyanosis, that is blue skin tone, rapid respirations, rapid pulse, distended neck veins, ascites or fluid in the abdomen, edema in the ankles, and cold, clammy skin. Echocardiogram shows that her ventricular ejection fraction is 30%. Her systolic pressure is approximately 100 millimeters of mercury with a reduced pulse pressure. She's treated with digoxin and a diuretic and placed on a low-sodium diet. This woman's signs and symptoms are a classic presentation of heart failure. The patient has a history of angina, or chest pain, which suggests that blockage of the coronary arteries has resulted in insufficient blood flow to the heart. With insufficient coronary blood flow, there is inadequate oxygen delivery to the working myocardial cells, and the ventricles are unable to develop normal pressures for ejection of blood during systole. A negative inotropic state develops in the ventricles, resulting in decreased contractility and decreased stroke volume for a given end diastolic volume. That is a downward shift of the Frank-Starling mechanism. For this, you can see figure 4-21. The decreased stroke volume is reflected both in the reduced pulse pressure and the reduced ejection fraction of 30%. A normal value is 55%. A smaller than normal ejection fraction causes a smaller than normal fraction of the end diastolic volume to be ejected during systole. Although not stated explicitly, the cardiac output also is reduced. Cyanosis and easy fatigability are signs of inadequate blood flow to the tissues and inadequate oxygenation of the blood. This woman has edema, which is accumulation of interstitial fluid in the lungs, as evidenced by shortness of breath and in the peripheral tissues. Edema fluid accumulates when filtration out of capillaries exceeds the capacity of the lymphatics. In her case, there is increased filtration from capillaries because of a rise in venous pressure. The patient has distended neck veins. The venous pressure increases because blood backs up on the venous side of the circulation, as the left ventricle is not able to efficiently eject blood during systole. Both the left and the right ventricles apparently have failed in this patient because edema has formed in the lungs as well as the periphery. Lung edema or pulmonary edema is a sign of left-sided heart failure, and peripheral edema as well as ascites and swelling in the abdomen is a sign of right heart failure. In this patient, the baroreceptor reflex is activated in response to a decrease in mean arterial pressure. This patient has a mean arterial pressure that is decreased because the blood has shifted from the arterial side to the venous side of the circulation, because the ventricle cannot pump blood into the arteries properly. And the woman's increased pulse rate and cold, clammy skin results from the baroreceptor reflex. That is, decreased mean arterial pressure activates the baroreceptors, which causes an increased sympathetic outflow to the heart and blood vessels, which increases heart rate and produces cutaneous vasoconstriction. This also causes a decreased parasympathetic outflow to the heart, which increases the heart rate as well. This patient's total peripheral resistance, if measured, would be increased as a result of sympathetic vasoconstriction of many vascular beds in addition to that of the skin. Also in this patient, the RAS, or renin-angiotensin-aldosterone system, would be activated by the low mean arterial pressure, and the increased levels of angiotensin II would contribute to the peripheral vasoconstriction. The increased levels of aldosterone would increase sodium reabsorption, total body sodium content, and extracellular fluid volume, perpetuating the cycle of edema formation. The treatment of heart failure involves two strategies. First, to increase contractility of the myocardial cells by administering a positive inotropic agent such as digoxin, although this therapy has fallen out of favor somewhat in recent years. And second, to reduce total body sodium content and the cycle of edema formation by administering a diuretic and by restricting sodium intake. This is very important for symptomatic control of these patients. Another therapy that has grown popular these days, due to recent studies that have shown mortality benefits, is to administer angiotensin-converting enzyme inhibitors and beta-adrenergic blockers to these patients. These drugs have shown to decrease negative remodeling in the myocardium and help to stem the worsening effects of heart failure on the dilation of the left ventricular chamber. This is the end of part 2 of the section entitled Integrative Functions of the Cardiovascular System.